Right. Good morning, my select few. Right, we have 4 of us. Right, I was saying a minute ago. Always gets hard at the end of the semester. Everyone's so tired and burned out, and 8:30 and good stuff. So I'm glad the 4 of you are here. Maybe some people will join us in a minute. I put this up here. I'm going to write this today, and I'll write it Monday as well. But our final exam is 1 week from today, which again coming up quickly. So what we'll do is we'll meet today, and then we'll obviously meet Monday. And then on Wednesday, we'll have a virtual class because it'll be the exam. So we won't be meeting in person. So our last traditional day will be Monday. And then on Wednesday, the exam will open up at 12:01 a.m. and it'll close at 11:59 p.m. So just make sure you are taking it on Canvas. And I'll remind you Monday, and I'll post an announcement probably Tuesday night as well. But it's just a 4th test, so it's not anything beyond that, right? So it's just a normal exam on the last units that we've covered. There's also a closing assignment that will be due, and I'll talk about that a little bit more. Maybe I'll talk about that at the end in case a few more people come. But there's also a closing assignment that I'll have you turn in on Canvas. So I'll write that up here as well. The closing assignment is worth 25 points, and it's like a little reflection that you're going to be doing on 5 things that you've learned over the course of the semester. So rather than giving you a cumulative final, that's kind of your cumulative element. So you can write that up. You don't have to study everything from the beginning, which I think is nice. Cumulative tests are the worst, so I swore to never give them whenever possible. But I'll talk about that a little bit more either at the end today or on Monday. But just to keep those things on your mind, I don't want them to kind of slip through and not be thought about. And then, as I said, what we'll do today is we'll finish up with the different therapies. We have the biological treatments to talk about, and then we'll get started a little bit on social psychology, which we'll finish up on Monday. So definitely, as I said, definitely down to it at this point. But last time we left off, right, we talked about all the different models of therapy, and then the alternative models like EMDR and light exposure therapy. So what we have today are the biological treatments. And these are really, really commonly used. Our culture, our society has a medication for everything, right? Like we have a pill for everything, and then a pill for all the side effects that pill causes, right? We just have so many different medications. And medication is probably the biggest thing here, right? So we'll look at some common groups of medications. There's some brain stimulation methods that are used in really severe cases of mental illness, or specifically usually depression. And then in very, very rare cases, things like surgery, but by far medication. And a lot of these are used with therapy, right? So maybe somebody is going to see a therapist and they're taking medication at the same time. That's really, really common. A lot of people do both to try and tackle things in a multifaceted way. So as I said, drug treatments, incredibly common. And we call this psychopharmacology, the study of the effects of different psychoactive drugs on the mind and on behavior. And there are just an incredible number of categories of these drugs. And I'm just have some of the really common ones up here, but obviously there are even more than this. But we'll talk a little bit about antidepressants, mood stabilizers, antipsychotic drugs, benzodiazepines, and stimulants are some of the more common categories. And probably the most common are antidepressants. A lot of people take antidepressant drugs. They're used to combat depression, hence the name, but they're also used a lot for anxiety and a lot of other different things. So antidepressants are probably the most common of all the categories of medications. And I'm sure you've seen commercials for them on TV. They're always on TV. And I'll probably play one commercial for you in a little bit as we look at some of the side effects. But there are 4 main types of antidepressants, and I have them arranged up here from oldest to newest. You can also kind of think about it as worst to best. And I'm going to write them up here on the board as well. So we have the MAOIs and the tricyclics. Like have to hide behind the screen. My brain was like not spelling tricyclics correctly. Still didn't, did I? Try sick. Yeah, it just looked weird for some reason today. SSRIs. And then SNRI. And I put a line through the middle of these because these ones up here are quite a bit older. And they tend to have a lot of side effects. Versus these two down here are much newer. And they have less side effects. So if you went to a doctor and they wanted to prescribe you an antidepressant, they would probably just prescribe one from down here, right? These are much newer. They're like in the last like 10 to 15 years. We have quite a few of these. They're much more specific and targeted versus these ones up here came out in like the 1950s, 60s, and 70s. They're very, very rarely used at this point. And I have a little video that introduces these really nicely. It's not super exciting, but I think it's really helpful. So I'll play it for you, but it gives you a little introduction to some of the different elements of each of these groups. And I'll write a little bit more on the board to go with it. I'll just pause it, right? Like I said, my blood pressure was ridiculously high. I almost had a seizure from it, not even from an antidepressant, just from interactions between two different medications. But what you see with all of these different medications that are here is they all have a slightly different way of working. And I wrote a few comments for each one up on the board, and we can talk about them a little bit more. Again, starting at the top, the MAOIs, or the MAOIs, monoamine oxidase inhibitors, right, which is up here on the slide. These drugs, really old, 1950s, right, almost never used anymore. The most common one is called Nardil, probably not even one that you've heard of, but they work by reducing an enzyme that occurs in the body called monoamine oxidase. And monoamine oxidase has a lot of different kind of properties to it, but it's kind of a controlling enzyme that plays a role in the release of other enzymes and neurotransmitters. So it has this crazy indirect effect, right? It reduces MAO, monoamine oxidase, to thereby increase serotonin, norepinephrine, and dopamine. So it's affecting a lot of different things, which is why it causes so many side effects. It's not very targeted or specific at all. And in the 70s and 80s, 1970s and 80s, we developed the tricyclics or tricyclics, and they cut out one step, right? So all these ones do is they work to increase serotonin, norepinephrine, and dopamine, right? And so they're a little bit better. They're cutting out one element. The most common one here is called Elavil. Again, very rarely used, very rarely prescribed. Both of those drugs are older, right? So they're never going to be the first wave of defense that somebody would choose. These ones are the SSRIs and the SNRIs. SSRI stands for selective serotonin reuptake inhibitors. And what these do is they only work on serotonin, right? They're selective, only on serotonin. And so what happens is because they only affect one neurotransmitter, the side effects are just drastically less. These are much more targeted, much more selective or specific drugs. And these are ones that are very common, right? Prozac, Zoloft, Celexa, and others, but those are probably the biggest three. And so oftentimes a doctor will start here with an SSRI, depending on the symptoms that you're presenting. Again, depression can take a couple of different kind of presentations. So depending on that, you choose one of these categories. The SNRIs, serotonin and norepinephrine reuptake inhibitors, are very similar, and we add norepinephrine, right? So these ones work on serotonin and norepinephrine. And the most common ones are Cymbalta and Effexor. And so what you see is when it says reuptake inhibitor, right? What that means is whenever our neurons are communicating with each other, remember way back, we talked about this forever ago, one neuron is going to release across the synapse all those neurotransmitters, right? They release from the terminal buttons, they float across, they're picked up on the other side, and then they keep that message going. Once that message has gone from one neuron to another, those neurotransmitters are brought back into the neuron. That process of bringing them back in is called reuptake. So if we prevent reuptake from happening, then there's going to be more serotonin or more norepinephrine or dopamine in the synapse. So we're creating more by not allowing that neurotransmitters to be reabsorbed into the neuron. So that's the way that these are working in general. They're trying to fix that chemical imbalance. But different categories, again, these ones are by far the most common. And you see commercials for them all the time on TV. I don't know if any of you ever consciously pay attention to drug commercials, but I find them fascinating, right? Especially because of the side effects. Like my partner and I have like an ongoing like joke with medications, like which one is going to be the worst. We were watching one last night and I forget what, we were watching Ozark because it came back, right? And we were excited to watch that. Or we were watching, no, it was Tournament of Champions. We're watching Food Network, right? That's what it was. I'm like, there's no commercials in Ozark. And there was a commercial for a medication to fight like psoriasis. And it had side effects of like instant death, seizures, strokes, rare tumors. I was like, forget it, I'll just have itchy, dry skin, right? Like, I don't know if you ever listened to these, like the side effect profiles, but they're required by law when they advertise these drugs to tell you the most common side effects. And that is the most difficult part with these medications. A lot of people cannot tolerate the side effects. Has anyone known someone who's taken an antidepressant before? Anyone known someone who's taken one? Was it helpful? Do you?
Instances where like the first two like tracing that start would be years.
If somebody can't tolerate one of the newer drugs, they might consider going back and trying it. Honestly, the MAOIs, they're just not used anymore. They're not good drugs. They were good at the time. We've just come so much farther in there. But if somebody can't tolerate one of the newer medications, we might try going back to like the medication. And again, like every drug has a side effect profile, so maybe they might be helpful, but they're just really not common. Right. So it would be kind of a rare circumstance. Anybody known someone who's been on an antidepressant? Yeah? Yeah.
I don't think so. I think it was like
Okay.
was like something from
What
and then I think she switched to something else.
Sure.
And, you know, one of the side effects is like weight gain, and she seems so much happier. She really needed time with that for the fun.
Yeah. They can be life changers. If you find the right medication, the right dosage, and if you tolerate the side effects, they can be just absolutely life-changing medication. Somebody who is very depressed and can't get out of it can all of a sudden be okay. And sometimes this is just chemical, you know, it's just neurotransmitter based, and so we change the neurotransmitters and they're fine. But yeah, it can take some time. So if you've ever known somebody or somebody you know like goes to try one of these, it's often a lot of trial and error, right? You go into a doctor or a psychiatrist and they're going to start with one of these. And so they'll be like, okay, the symptoms that you have, I'm going to try Prozac, right? And so they put you on Prozac and it takes a couple of weeks for it to get up to like enough of a concentration in your body. And then at that point you see, is it reducing the depression and what are the side effects that it's creating? And if it's working, great. If it doesn't work, then you have that person go off of that medication and then maybe you try Cymbalta and see how they respond to that. Sometimes somebody will take a medication and then we have to give them another one to handle the side effects that it creates. Unfortunately, that can happen as well. So it's not always as simple as like, oh, here's an antidepressant and you'll be better. Some people have a really hard time tolerating the side effects. Some people don't respond to them. But when you find the right one in the right concentration, again, it can be very, very helpful. I have an example. I just went on YouTube and typed in antidepressant commercial. And the first one that came up was a Cymbalta commercial. And so I want to play this for you. I just want you to listen to the side effects. These are very common ones. But again, every commercial that anyone who's advertising one of these, they have to give you the side effects by law. Let me bring up this one. I recorded it a little better. Hold on one second. Forgot to. Can't post it if I put that in there. for these medications. And that's a lot, right? Like, okay, so you don't feel as depressed, but you have yellow skin, blisters, hives, and some fatal liver conditions, right? So again, they're mixed. Any medication that you take has upsides and downsides to it, right? Even things like Tylenol or cough medication, like anything can have a mixed effect. So it's finding the right one, finding ones that you can tolerate. And hopefully, if you can get there, right, they can be very, very helpful in alleviating depression or anxiety and a lot of other things. The mood stabilizers do exactly what they say. They stabilize your mood. Really, really commonly used for bipolar disorder. So if somebody's going like this, like they have a lot of like ups and downs, it kind of brings them into the middle. So it brings the highs down and the lows up. So somebody's kind of more leveled out. It's much better, or these drugs are much better at bringing down the mania. So it might be that somebody takes a mood stabilizer and an antidepressant to tackle both sides. The most common mood stabilizer is a drug named lithium. Kind of an older drug. It can be a little bit dangerous. You have to be monitored with blood tests. But it is one that we prescribe quite a bit for mood stabilizing for bipolar disorder. The antipsychotic drugs are used for schizophrenia, right, to fight psychosis. And these by far are the most difficult drugs to tolerate. They have a lot of side effects. They tend to help with dopamine specifically. So people who have schizophrenia, it's thought that they have too much dopamine. So antipsychotic drugs reduce the amount of dopamine in the system to reduce hallucinations and delusions, but they cause a lot of tremors and like Parkinsonian-like symptoms is really, really common. The benzodiazepines are used a lot for anxiety. Xanax, Valium, those are medications that would fall into the benzodiazepine category. They help to reduce and enhance GABA by reducing anxiety. So reducing anxiety, changing the GABA, which is a neurotransmitter in your system. And so they play a really big role in that. They can make people very sleepy. They have kind of like a sedative quality to them. And then psychostimulants are used to help stimulate people. And this is a really counterintuitive, but stimulants are often used for ADHD. Right? So people who have ADHD take stimulants like Ritalin. Right? And the thought is that they're actually very understimulated. So by stimulating their system, you actually help them to calm down. Right? So Ritalin is a stimulant, which is often given to people who are struggling with ADHD. So again, these are just some of the categories. There are quite a few more. People sometimes take medications to help them sleep at night. There's a lot of those. There's a lot of things like barbiturates. There's a ton of other categories, but by far antidepressants are the most common. And then these are probably next, right? A lot of people take Valium and Xanax and medications like that to help with anxiety. Any other thoughts or comments or stories or questions? Anything else about the medications? Yeah. Yeah.
Like she went into the doctor and she immediately got prescribed Xanax, but I thought that's like a lot more heavy drug. So would that be like the more severe cases?
It can be. Xanax is a tricky one. It's not something that you can take like every day all the time. It makes you incredibly sleepy, right? Because it has a sedative quality to it. So oftentimes people who are having like a lot of anxiety will take a Xanax, and it's often before bed or like in the evening. You can take it during the day, but it does tend to make you get tired. So it's usually like a short term, or like I'm having a really anxious day or a really anxious like period of time, so when I take it now. So they're used kind of sporadically in that way. So it could be that it's more severe, just be the doctor's way of maybe trying to help, help that person to calm down a little bit. It doesn't tend to be a great long-term solution. Yeah. And I don't know if any of you, it's always in the movies, it drives me nuts, right, to see this in movies. But people in movies will like take a Xanax, so like put it in their mouth and then they're calm and they're better. It takes like 20 to 30 minutes for your Xanax to kick in. So that's kind of that placebo effect of like, oh, I took it, I'm gonna be okay. Right. And so sometimes just having those medications available to you is enough to make someone feel better. Like if I need it, I have it. I see that all the time, right? I forget, I was watching a movie that was like 2 weeks ago. the woman took a Xanax and was like, totally fine. Like, it's been 30 seconds. It hasn't worked. But the power of the mind is incredible. And so if you think it's going to help you, it often will. Did you have a?
A little stupid question, but like Xanax, if you take so many, can you like start seeing stuff?
Sure. Yeah, it could cause you to hallucinate. And one of the ways that it tends to do that the most is sometimes people will combine these with alcohol, which is actually incredibly dangerous.
Yeah.
When you combine a sedative with another sedative, which alcohol is a depressant, these are a depressant. When you combine them together, it can be fatal. But it always makes me think of Bridesmaids. If you've ever seen Bridesmaids, right? Helen clearly gave her a Xanax or like a Valium, and she takes it with alcohol. And so she starts hallucinating, right? And there's a continental woman on the wing and she's like acting all loopy, right? When you combine them together, they can actually be very, very dangerous. But it's common, people abuse them that way very often. Mm-hmm.
So he did like midnight.
Yeah.
I called him. He was like, they're in my backyard. Like, he was like afraid.
Yeah. Yeah.
So I didn't know if it was 9 or if it was about that.
Either. I mean, taking 9 of them and mixing it with alcohol could be incredibly dangerous, right? Oftentimes people end up in emergency rooms for combining drugs together. But yeah, if you take more than you're prescribed, it could definitely cause you to hallucinate or sleep for a very long time, or, you know, maybe not even wake up, depending on how much of it you took. They could cause a drug-induced coma. So it's important to take them as prescribed or closely to, because they can be, you know, pretty dangerous otherwise. But they're often abused that way. People abuse these medications just as much as, you know, as more illegal substances. Not my favorite either, right? But yeah, I mean, you know, it's something, sadly, you know, sometimes we have to get used to, right? Over time. Anybody else? Other thoughts or questions? Yeah. Yeah. Mm-hmm.
So that's something we just regulated?
Yep.
Would it be the idea? So I was thinking maybe it wouldn't be that they got overstimulated, so therefore they have too much energy, so they shouldn't go down.
Yeah, the thought is that they're actually understimulated, that their brain is understimulated. So we stimulate it and then all of a sudden you calm down. And it's really interesting, people who, like, we all have different brain chemistry, right? Every single one of us reacts differently to substances. But very common, someone with ADHD, if they drink a cup of coffee, they actually might get sleepy or calm down. It's not a diagnostic criteria at all, but it's kind of an informal one. Like, my partner has ADHD. She could drink a cup of coffee like in bed and go to sleep. Like, if I drink a cup of coffee after like 3 or 4 in the afternoon, like, I won't sleep tonight. Like, it just, that's how it affects me. There's no way. And so oftentimes people who have ADHD self-medicate that way. Maybe they drink coffee before school. My nephew takes chocolate covered espresso beans, and when he goes to school, to help him calm down. And so it's a very like opposite reaction of what you would think, but it's actually pretty typical for individuals who have ADHD. Yeah. Seems so counterintuitive, right? But it tends to be how it works. All right. Much less common, brain stimulation methods. You would never have these be the first line of defense. Like, you wouldn't go to a doctor with depression and have them be like, great, we're going to do some, you know, deep brain stimulation. Like, that would never happen. These are typically used when somebody does not respond to medication, or their depression or mental illness is so severe that it's life-threatening in some way, like they're deeply suicidal, not able to function. These are used with a relative amount of frequency. They're just never going to be the first line of defense. And so what happens with all of these is we are stimulating the brain in some way through a couple of different methods. There's a brain circuit related to depression, and this is beyond what we need to cover in here, but there are different structures in the brain that are very correlated to depression. And one of them is the frontal lobe. And so it's thought that if we can stimulate and activate the frontal lobe, that we actually reduce depression in people. And that's the idea behind these different methods. And there's one that's very, very common. It's old, but it's common, and it's called Electroconvulsive Therapy, or ECT, sometimes called shock therapy, but ECT is the formal name. And the idea with this is they put a little electrode on either side of the head, and they run an electrical current through your brain, causing you to have a seizure, a clonic seizure. You lose consciousness for at least 2 seconds. And it's thought in some way to like activate and almost reboot the brain, right? It's activating the frontal lobe. It's activating a tiny little area called Brodmann 25. You don't need to know that. But it is activating different parts of the brain in order to increase serotonin, in order to increase activity and blood flow. It has a lot of side effects. People who receive this oftentimes have memory loss and confusion. It used to be a very violent procedure, right? Where they would have to hold patients down because they would have such violent seizures. Now it tends to be something where we give a muscle relaxant. It's much less intense, but it tends to be something that you go to like 6 to 12 rounds of. It's not a one-time thing. It's like 6 to 12 sessions. It's an outpatient procedure, right? Someone has to drive you there or drive you home rather. But it is something that you can go to and then you come home afterward. And oftentimes people are very tired, but it's not as invasive as it used to be. Now, the stereotype of this is actually pretty like invasive. I have a clip of this from a very old movie, One Flew Over the Cuckoo's Nest. Classic psych film. Like if you've never seen it, it's a great old psychology film, like back in the like 50s, like mental hospital era. But let me play this for you. You can see what this used to look like. Again, it's much more humane now, but this is kind of the laying him down. Sometimes people are strapped down during this procedure, but it's definitely been refined over the years, but it is still practiced. It is a relatively common procedure for people who have very severe depression. Now, there are newer ones, thankfully, that are way better. These two, this one and this one, not so much. But this middle bullet right here, TMS, transcranial magnetic stimulation, is starting to gain a lot of popularity. It's so much less invasive, right? What they do is they put a small magnetic coil over your head, and it activates an area deep inside the brain that is in charge of serotonin. And it doesn't cause a seizure. You're wide awake and like fully functional during it. The only reason it's not more popular is it's incredibly expensive, like $10,000 per round of treatment. It's not covered by insurance versus ECT sometimes is. So it's gaining popularity, but the cost of it is keeping it from being accessible to more people. But again, all of these are much more intense, severe, invasive procedures, but they are some biological approaches we can take if somebody isn't responding to more traditional stuff like medication. Thoughts, questions, anything here? Yeah.
I have been getting ads on like my Instagram for like microdosing, like mushrooms and like what else? Like doing treatments for that.
Yeah.
As well.
Sure. Yeah, people try all sorts of things for mental illness. And I have to tell you, I was doing a Google search for transcranial magnetic stimulation for my abnormal psych class, and I was just looking for a video clip of it. And the things that I found were like really frightening for what people were doing to stimulate their brains at home on their own. Like as a parent, guys, please don't try and like do at-home brain stimulation. Just don't, right? But there are all these videos of people like wiring magnets together. You know how we get on YouTube and go down like a rabbit hole? I just went down like the rabbit hole of brain stimulation.
Yeah.
And it was all these videos of people wiring multiple batteries and like putting coils and tinfoil next to their head and trying to stimulate their brain. Don't. No, don't do that. I mean, and the idea is they're trying to activate parts of their brain. People take substances to try and do that. There are even types of therapy where, they've had couples take mild levels of ecstasy to try and change the way that they interact with each other. Anytime that you're taking like those situations, it's like you're creating new issues oftentimes. You might develop a dependency on one of those substances, and sometimes those substances can actually make the depression worse.
Yeah.
So it's slippery. It's a slippery slope. Like the idea is that people are trying to help themselves through microdosing, right? But those things without any kind of supervision from a physician can be dangerous if done improperly. But yeah, don't ever stimulate your own brain on your own with batteries. Okay, just don't do it. If one day you're thinking about it, remember me saying that, right? Yeah.
It would cause problems if it went completely wrong on ending them.
This with electroconvulsive therapy. Yeah, I mean, so we first started using electroconvulsive therapy back in like the 1930s. So we've been using it a long time. Really interesting side note, like the first patient who ever had this done was a patient who had schizophrenia, hadn't spoken a word in like over a month. And they ran an electrical current. I forget how many watts it was. It was a lot. Like they ran like a massive current through this guy. And he survived and he sat up and basically swore at the people who did it. And they were like, success, right? He spoke. And so we've been refining it ever since. So as shocking as it is that we still use it, every pun intended, it is actually something that we have gained a lot of like knowledge. You sign a waiver, obviously, you know, any procedure can have side effects and consequences. You know, I wouldn't say a friend, I had someone I knew who went through electroconvulsive therapy, and she had incredible amnesia as a result of it. Like she couldn't remember hardly anything, and that can happen. So again, it's something you have to weigh, you know, like how bad is the depression? How life-threatening is that versus the potential like risks of doing, you know, something like this. So yeah, I mean, they you sign a waiver basically like agreeing to whatever could happen, and it can, but it's not as dangerous as it seems like it would be. Strangely, right? It seems like it'd be really dangerous, but it's not so bad. The last thing here, psychosurgery. So this is something that you would only do in very extreme cases. And I can't remember if we watched this or not. I think I put it in the lecture video way back. Do you remember the guy Joe who had his corpus callosum severed? I think we watched that. I can't remember. I remember we watched it way back in the brain unit. Sometimes when people are having really intense mental illness, every now and then there's something that we can surgically repair, right? Maybe there was like some kind of head trauma or separating the corpus callosum, allowing seizures to be isolated. Very, very uncommon. There's not a lot of these surgeries that take place. This was much more like in the past that we would perform things like lobotomies and trephinations and things that people often died as a part of, because they were very very brutal procedures. But today it would be more something that like if there was something that we could surgically repair, of course we would do that. It's just not a very common procedure at all. So this would be like a last resort. Traditionally, within this method, it's medication, right? We're talking about medication as the vast majority of cases, but then those brain stimulation methods sometimes in this incredibly rare. Last comment for this chapter. Sometimes people with severe mental illnesses are hospitalized, but sometimes people have to go into like a psychiatric hospital of some sort. And it could be for a short period of time, or it could even be for a longer period of time. But psychiatric hospitals or mental hospitals have been around a very, very long time. Right? And interestingly, they had a really like good idea behind them. But when you think of an asylum, like what do you picture? When I say the word asylum, like what are some of the images that pop into your head? What do you see when you think of an asylum? Yeah. Season 2, right? Yeah, same, right? Really like dark and awful conditions. What else? What do you think of asylums? What do you think? What was that?
Creepy socks.
Okay. Creepy socks. What was that? Oh, okay. Gotcha. I was like, socks. That's different. I've never done that. I got you. Okay. Yeah, just like medicating and like I think of bad conditions, like dark, dirty, awful, people screaming, straight jackets, like everything bad, right? Like, but when you don't think of good things, when you hear the word asylum, like you don't want to be in an asylum. But the idea behind an asylum, which was the name of these first hospitals, was let's take people out of their lives and put them in a nice big house in the country where they can relax and recover. That's not at all what they became, right? But that was the idea behind them. Asylums turned into state hospitals or mental hospitals or psychiatric hospitals. And these hospitals, since the beginning, have been perpetually underfunded, understaffed, and oftentimes became more like warehouses or jails in a way for people who needed treatment in the past, right? In like the 50s and before, we didn't know how to treat people. So we just locked them away. A lot of brain stimulation stuff, a lot of medications, like shady stuff, right? All of those bad things that we talked about that we did to get to where we are today. And interestingly, a lot of these hospitals shut down or were converted to other things like in like the 1970s, 1980s and beyond, right? I always think of Cal State Channel Islands, right? Like it used to be a psychiatric hospital. I've never been out there, but people always tell me stories about it. Yeah. Like the abandoned buildings. Okay. That's disturbing, right? Interesting. And I smile. I'm like, ooh, disturbing, right? I mean, and yeah, like it has history, right? My first job, my first psychology job, I didn't get paid for it. I was volunteering, but I considered it a job. I went and I worked, right? Was at a psychiatric hospital in San Diego. It's now a YMCA. Like, it's so strange. I'll drive by and I'm like, people are working out. I'm like, I did group therapy in that room. It's so strange to me. But so many of these places, these massive state hospitals have been converted to other things. I took a college class. It was a 1-unit class on Buddhism when I was up at Humboldt State. I had a goal of like 1 random class per semester just to broaden my horizons. Probably one of the coolest things I ever did in schooling. And I took a 1-unit Buddhism class and we got to go to a Buddhist monastery. And when we got there, it was a converted old psychiatric hospital. And they're like, you'll be sleeping in this ward tonight. And I was like equally horrified and excited. Like I've never been so scared and yet so excited. Like they put us in this room and it had like lime green tile walls. Like you could just see how it used to be a state hospital. Felt haunted. It felt haunted as it was just ridiculously creepy in there. And I was so grateful. They separated the men and the women. They're like, we don't want you to be tempted by your partners. I got to be in a room with mine. Like, I was like, this is amazing, right? I wasn't scared. They were like, you two can be in a room together. I'm like, oh, okay. So they put us in this room and I spent the whole night just laying there listening. Like, it was so creepy. And even the monks, they had buildings that they hadn't been able to clear like the negative energy from. Like I would like completely didn't even care about the Buddhism at that point. I was so obsessed with this old abandoned hospital. But there's so many of them across the country, right? On these massive, massive state hospitals that got shut down or converted because they just couldn't keep them staffed and they were too expensive to fund. So now what we tend to do, since most of these are shut down, is we do like outpatient therapy. We don't have these massive buildings. Sometimes we have a ward within a hospital, like a wing or a small area. And we practice what's called de-institutionalization. So rather than putting people in these massive hospitals, we try and treat them more in the community or in like smaller public hospitals, because removing people from their lives, the second they go back, they have all the same issues again, right? So it hasn't been shown to be as helpful as we thought it would be. Better if you can allow someone to stay in their like normal life situation, but receive help along the way. So we don't tend to do this so much anymore, but it was very popular up until about like the 1990s. And now we practice more like smaller facilities. As a side note, they had the best rolls I've ever had in my life at the Buddhist monastery. They had a very strict rule, right? You don't take more than you can eat, right? And so like, they're like, take a little bit of what you want to eat. And like, if you want more, you can go back. And I took 1 roll and like, it always makes me think of if you like Lord of the Rings, like lembas bread. It was like, if you ate this 1 roll, you'd be full for a year. Like I remember being like, I can't even eat this 1 roll and I can put down bread. Like I can, and cake. But this 1 roll, I swear, was like the densest yet most delicious roll I've ever had. That's all I had. My takeaway from that class was rolls in psychiatric hospital, but really, really interesting at the same time. Any other thoughts or comments or questions? Anything else here? Before we leave it behind and go to our last chapter. It's crazy. I'm sentimental, so I'm like last chapter. Happy and sad at the same time. All right. So the last one, have I said last enough? I could say it again. The last chapter, chapter 16 is social psychology. And we'll just get a couple of slides in today and then we'll finish it up on Monday. But social psychology is as broad as psychology gets, right? Anyone in here taking a sociology class? Yeah, a couple of you. There's a lot of overlap between social psych and sociology. I actually almost majored in sociology instead because they have so much in common. They're really, if you like this, you probably would like sociology. If you like sociology, you might really like social psychology. Yeah. Yeah. Yeah, there's a lot of overlap, right? Psychology looks at how individuals are influenced by like group behavior here. Versus sociology is all about like norms and group behaviors and like constructs that we have, right? There's so much overlap. So yeah, and sociology is wildly interesting, just like social psychology. Yeah, right. And the same one, don't get confused, right? So we'll look at some of the kind of big ideas in this. This is a massive area of psychology. You can take whole classes, you can get a master's or a PhD in social psych. We'll just look at some of the kind of big concepts and ideas. And so, as I said just a second ago, right, social psychology is the study of the ways in which the thoughts, feelings, and behaviors of one person are influenced by the real, imagined, or inferred behavior or characteristics of other people. We live with other people, right? We are surrounded by other people. And whether we realize it or not, we are constantly being influenced by the presence of other people, whether it's real or imagined or just kind of inferred. Other people and the world and norms and culture influence us very, very heavily. And that's what we'll look at a little bit here. What are some of the ways that we're influenced? What are some of the things that social psychologists tend to study? And there are, as I said, quite a few of them. So we'll just look at some of the bigger ideas. One kind of big beginning starting point is looking at the idea of attributions. We're all kind of like little scientists in a way. Like when we meet someone new, we're often trying to figure them out, right? Like trying to figure out like how we can connect to them or what makes them tick or like what we can infer or guess about them. We make attributions about people. We're trying to explain things about people all the time. Some of us more than others, but it's very common. And so Fritz Heider is really well known for this idea called the Attribution Theory. That when we meet someone, we tend to give causal explanations for their behavior, either by saying, okay, that's who that person is, and kind of crediting their personality or their disposition. Or maybe we say, okay, the situation caused them to act in a certain way. Right, so we're constantly making these decisions about people when we meet them. You know, is this person acting because of the situation or is this who they are? Right? And that's a kind of a basic like attitude related concept for social psychology that we oftentimes forget to estimate the situation. Sometimes the power of a situational force can be so powerful that it overrides how you would normally act, right? Like maybe you're different in this class than you are in another class because of the time of day or the subject or the number of people who are in here. My daughter has a close friend who is always incredibly quiet at softball. At softball, she never says a word. You would think she's the shyest person in the world. And then when you see her in any other environment, loud, extroverted, just the situation of softball for some reason makes her like very, very quiet. So you have to consider personality and the situation when it comes to deciding why people are the way that they are. And we sometimes make a mistake called the fundamental attribution error, where we overestimate somebody's personality and underestimate the impact of the situation. And sometimes we do the reverse when it's ourselves, right? Like somebody who is a bad driver, who might be like, oh, they're an awful driver, right? Like clearly they can't drive. And then we get set in the same situation. It's like, oh, it's because the roads were slippery, not because I'm a bad driver, right? We tend to have that like kind of assumption. Or like the one I just gave you with my daughter's friend, Amelie, right? Someone is shy and quiet and introverted. Like there are some of you who have never said a word. in this class, and I could assume that you're maybe like very shy or introverted, or again, maybe it's just this class or me or the time of day or the subject or whatnot. I make this mistake, or I used to make this mistake all the time at Target. Like I'd see parents yelling at their kids, like, what an awful parent, right? Like yelling at their children, and like not taking the situation into account, right? Sometimes Target is a rough place with kids sometimes, right? They want everything. And so sometimes we forget to take into account the impact of the situation for other people, but we overestimate it for ourselves. It's a very, very common mistake that we make when trying to analyze the behaviors of other people. One other really big kind of area, and this will take us a little bit more to talk about, social influence. How are we influenced by other people? How are our perceptions, attitudes, and actions influenced by others? And we'll look at a few things like conformity and obedience and compliance and norms. We are constantly being shaped by the people around us, by the media, and by all sorts of different things. And the biggest way that we see this is through norms. There are norms for everything. Rules or expectations about how we're supposed to behave. Every single one of you right now, sitting in your desk, looking at it. Every single one of you. Can you imagine if one of you was like standing in the back corner staring at the wall? Like we would all wonder like what the hell you were doing, right? Like it would be distracting because it would be abnormal, right? It wouldn't be normal, it wouldn't be the norm. No one's wearing Halloween costumes today because we're in May, right? I said April, we're in May, right? It's not appropriate to wear a Halloween costume to school on May 4th, right? Oh, may the 4th be with you. Today's May 4th, right? Star Wars Day, yeah. Oh, happy birthday to the doggo, right? And it's Star Wars Day. I completely forgot. I should have worn like a Star Wars shirt. Oh, my lightsaber. My daughter's lightsaber. I don't have a lightsaber. Maybe. I have a Chewbacca mask though. That Chewbacca mask that I showed you that clip of, I do have one of those. We could have had the whole class wearing Chewbacca masks. But there are norms for everything. Elevators. Elevators are a great example of a norm. What are you supposed to do in an elevator? What's the norm in an elevator? You stand there, quiet, you face forward, right? Don't talk to anyone. Don't do anything. Right? I love to get in elevators and turn around. You can see the look on people's faces. They're so uncomfortable. I get into an elevator, I push the button, and then I turn around. And they all have that, like, what are you doing? Like, look, because it's not what you're supposed to do. I don't know why it amuses me so much. I started doing it years ago, and now I just can't stop. But I had a couple turn around. Like, they followed my norm. I got in the elevator, pushed the button, and turned around. And I was staring right at them, and so they turned around. I was like, this is amazing, the power I have right now. Right? There are norms about how to behave in an elevator. There are norms about what we eat and don't eat in our culture. On our honeymoon, we went to Puerto Rico for our honeymoon. It's still technically part of the United States, but very different from here. We went out to a restaurant for dinner. The first item on the menu was fried breaded brains. You would never find that at like Chili's, right? Or like TGIF or whatever, right? Like you wouldn't find that here. That's not something that we eat. We don't tend to eat dog in our culture. It's a pet, right? It's your dog's birthday. You would never consider eating your dog, but there are cultures where dog is a delicacy, right? Every culture has different norms. Every group has a different norm. You have norms with your friends that might be different than norms with your family, right? And so we follow norms quite a bit. They're expectations about how we behave, and they can shape our behavior, whether we are aware of them or not, right? Maybe you feel like you have to follow a norm in order to fit in or not stand out or whatever it might be. And one of the ways that we see this play out quite a bit is in the idea of conformity. Most of us at some point have conformed so that we don't stand out, right? Maybe it is you went along with the group so that you didn't seem like the one who had issues with everything, right? Group behaviors is a lot of conformity. We'll talk about that more next week. Maybe it's what you wore, right? Or maybe it's the things that you said or the things that you did. Very, very common that we adjust our behavior to coincide with a group standard. And there's a very famous experiment of this. It's old, it's classic, which means it's old. Solomon Asch did these experiments where he had a group of participants and he wanted to see if he could make the one person who was not part of the experiment conform in their perception of lines. And so I'm going to play it for you. It's old and you can laugh at their hair and their clothing, right? It's very different. But what you'll see is the person oftentimes looks very confused, or they know that they're right, but they go along with the group because they don't want to stand out, or they're afraid they might be wrong because everybody else is agreeing. And so this is a great example of conformity. Play it for you. There's a guy in a red shirt who's very proud of himself because he thinks he gets everything correct, right? He doesn't know he's part of the experiment, which makes it funny. But let's see. Where are you? Oh, I'm in the wrong class. That would help. Here we go. Experiment. And I love the guy in the red shirt. Like every time he has to look at his partner, like you and I know what's up. Like everyone else has no idea what they're doing. But very common that people go along with stuff, right? They don't want to stand out. They don't want to call attention to themselves. So they conform. You give up your own preferences and you go along with the group. Very, very common way that we see social influence play out. Maybe you have a different opinion than all of your friends, but you keep it to yourself because you don't want to stand out or make waves, right? Or, like we just saw here. So it's very common to see people conform and go along with group preference or group influence. And we'll talk about compliance and obedience and a few of those other ones next time. I want to take just a minute. I mentioned this at the beginning here. We'll bring this up. Hold on. Our next class, right? We will keep going with social psychology, right? So we have a little bit more related to that. Going to have any more windows open here. So with our next class, we'll have that pop up. But on Wednesday next week, right? We have our final exam. I talked about this at the beginning, but there's a lot more to do. So I just want to remind you that Monday is our last day of like normal class. So Monday we'll wrap up the last of our slides. So we'll get to the last one. And then on Wednesday we have exam number 4, which is the final exam. The study guide's already on Canvas. So you can start preparing and studying for that. It is just a 4th test. You can use your notes. You can use your book. It's the same style and format as the other ones you've taken on the ebook site. And then there's also a closing assignment that will be due that day by 11:59 p.m. And I can see a few more things about it on Monday, but basically what you're doing for this is you're writing me a short paper, right? You are reflecting back on 5 things that you can apply to your life in some way that we've covered this semester. And I hope there's more than 5, but you can look over the syllabus, you can look over the list that's online, and you're going to come up with 5 concepts that you can apply, 5 terms or concepts. And this isn't a traditional like essay. Basically what you'll do is you'll have number 1, you'll have your term or concept. You give me a definition. And then you'll describe how you could apply it. So we'll talk about application. So you'll follow this format, make it very easy for me to see this is my term or concept. So let's say you choose conformity, right? We just talked about that. So then your term or concept will be conformity. You can copy verbatim the definition right here. And then you would talk about how does that relate to your life in some way? How could you apply that? Okay, and so this should be about a paragraph. This is the part that I'm looking for. This piece here is what is worth the points, right? I'm looking to see that you can take that concept and apply it to your life. And so maybe you talk about a situation that happened where you conformed, and now you understand maybe why you did that because of what we covered in here. Then you'll move on to number 2, and you'll do the same thing, right? So you're not necessarily writing me an essay. There's no transitions. You're just following this format. So each one of these is worth 5 points to make 25 points in total. And you're submitting this online on Canvas. You'll see the instructions are there and there's a link there. And I can show you that one more time on Monday. But you can start doing this now. It's open and available for you to do now. It's due by Wednesday night at 11:59 p.m. And this is that cumulative element. So rather than giving you a cumulative test, this will allow you to think back over the class without having to study everything that we've covered. So I'll say a few more things about that on Monday, but I just want to make sure you're thinking about all that, start preparing for the exam. There's not a lot of, there's basically one participation left. And we have one class left, so you can guess when we'll do that. And then we have the exam and the closing assignment. So we still have like 135 points left. You want to make sure you get all those, obviously. So start preparing and working toward that, and have a wonderful weekend. And I'll see you all on Monday for our last lecture. I know, I'm sorry. I'll stop. I'll try and stop. That's the last time I'll say it today. No, I'm just kidding. All right. I'll see you all on Monday. Have a wonderful weekend.